Hi, my name is Barry Doyle. I'm a lawyer in Skokie, Illinois, practicing nursing home abuse and neglect work throughout the state of Illinois. I'm here today to talk about a citation that the Illinois Department of Public Health issued to Bridge Care Suites Nursing Home in Springfield after a resident there died of an infected bedsore or decubitus ulcer. Now, bedsores and decubitus ulcers are different terms for the same thing. Essentially, this is a breakdown in the skin that unfortunately leaves residents susceptible to developing infections such as cellulitis or osteomyelitis, which is an infection of the bone. There are specific federal regulations that apply to nursing homes which address the bedsores in the nursing home setting. The first of these addresses a situation when a resident arrives at a nursing home without a bedsore. In essence, it provides that a resident should receive care, treatment, and services necessary to prevent the development of bedsores unless the resident's clinical condition demonstrates that they are clinically unavoidable. The other regulation addresses a situation once a resident has a bedsore, whether it's one that was developed elsewhere or develops in the nursing home. In essence, what it provides is that the resident is entitled to receive care, treatment, and services consistent with professional standards of care necessary to prevent infection, promote healing, and prevent the development of new bedsores or pressure ulcers. Because there are these regulations that are enforced, bedsores are a major source of focus within the nursing home industry. It's a issue that is specifically addressed in the care planning process. Typically, a resident will undergo an assessment known as a Braden assessment, which is intended to assess a resident's risk of developing bedsores. And there are a number of factors which put people at risk for developing bedsores. The three main ones are immobility, incontinence, and poor nutritional status. Now, when a resident is at risk for developing bedsores, a care plan has to be developed. Typically, this will include a series of interventions which are intended to address the particular risks that the resident has in connection with their chance of developing bedsores. Most often, this will include some type of pressure relief, whether it's offloading, whether it's the use of pressure relieving devices or a turning and repositioning schedule. Frequently, it will include the use of nutritional supplements or extra servings of protein to help the body's protein levels maintain so that skin breakdown is less likely to occur. It will often include the use of things like barrier creams, which are intended to prevent urine and feces from breaking down the skin. When a resident develops a bedsore, or if a resident has a bedsore and it's declining, getting worse, this is a situation that requires the nursing staff to notify the doctor. And the idea behind this is that when a resident either gets a bedsore or has a bedsore which is declining, then the doctor can go ahead and issue orders for new orders for care, can refer the resident to a specialist, a wound care doctor, or wound care nurse for special care with somebody who has specialized training in addressing bedsores. The other thing that should happen when a resident either develops a bedsore or has a bedsore decline, this is a sign that the care plan isn't working and it needs to be updated and revised to reflect what the resident's current needs are, as well as the fact that whatever interventions or steps had been put into place simply weren't working at that point. So this is a resident who was admitted for a short-term rehab stay after falling at home and breaking a hip. And the expectation is that this resident would receive some rehabilitative services over the short term and eventually be discharged to go home and live with her son. When the resident actually entered the facility, she already had a bedsore. It was 3 by 4 centimeters on her coccyx, which is her tailbone. Now, Usually when someone is admitted to a nursing home and already has a bedsore, the usual practice that you will see is that the admitting nurse will contact the doctor for orders. That wasn't the practice here at this nursing home. What was being done at Bridge Care Suites is something I hadn't seen done anywhere else, and that was when a bedsore is a stage 1 or 2, then they would not contact the doctor for orders. Generally, that would be done after a bedsore is stage 3 or higher. To give you some context for what that means, a stage 1 bedsore is something that most people wouldn't even notice, and what that essentially is, it's an area of non-blanchable skin. Blanching the skin, basically what it amounts to is when you put pressure down on your skin and there's a white spot, eventually that will pink back up. That's blanching of the skin. When you have non-blanching skin and you put pressure on it, it remains white for an extended period of time. Most people wouldn't even recognize that they had a stage 1 bedsore. Stage 2 involves the very outer layers of skin, and these are things that most often can be treated successfully. Stage 3 has some depth to it. It's into the subcutaneous tissue, and then when a bedsore is a stage 4, that's considered the worst level, and that involves exposed muscle or bone. So when this resident came into the facility, the facility wound care nurse didn't reach out to the doctor to obtain orders, which indicates that this was probably a stage 1 or stage 2 bedsore. This was something that inherently wasn't a fatal condition. It is something that very well could have been healed. Now, within 19 days of this resident having been admitted to the facility, the wound had declined to a stage 3 bedsore. There had been a care plan put into place. The care plan included the use of a pressure-relieving cushion on the wheelchair, but it didn't include some of the traditional interventions that you would normally see, such as offloading, using other types of pressure-relieving devices, or a turning and repositioning schedule. Those components that are customarily seen just aren't there. Now, once the wound declined from a stage to a stage 3 wound, there was an entry made on the medication administration record for treatment orders. Generally, when you see things entered in on the medication administration record, those are associated with physician orders. In this case, there weren't orders obtained from the physician. Those were simply entered onto the chart by the wound care nurse, and that was for use of a foam dressing to be changed every other day. Now, to his credit, the wound care nurse did get a referral for the resident to be seen at the wound care clinic about a week later. So when the resident arrived at the wound care clinic is where the story really does take a turn. Because the nurse practitioner who was the wound care specialist could see that the resident was on a regular wheelchair cushion, not a pressure-relieving wheelchair cushion, and that the resident had this dressing in place with the foam dressing, which is something which was inherently inappropriate for the kind of wound that this resident had at this point. And what the nurse practitioner told the state surveyor was that had they been contacted and advised that the resident had this kind of wound, they would have issued other more appropriate orders for treatment of this wound other than the one that the nurse practitioner or the facility wound care nurse came up with on his own. The thing that was eye-catching about this survey was how the nurse practitioner described what she saw. And she told the state surveyor flat out that she was mortified by the condition of this resident. She described it as a nasty, nasty wound that stunk. The wound had gotten larger in size. There's plenty of slough within the wound bed, which is dead tissue, which is an indication of a wound that is worsening. There was tunneling underneath the edges of the wound, and there was bone that was palpable at the base of the wound bed. The nurse practitioner debrided the wound, meaning she cut away the dead tissue, which is a very common step to take where you have dead tissue within the wound bed. And noted that this was a wound that was going to require multiple debridements. Now the resident was returned to the facility, keeping in mind that even though the wound was at this point a stage 4 wound, because it had exposed bone at the base of the wound bed, there was no change in the care plan. The care plan remained the same as it had been when the resident came into the facility with the stage 2 wound that was there on admission. Now, 4 days after the resident was seen in the wound care clinic, she began to experience and make complaints of significant pain to the coccyx, level 5 out of 10, 7 out of 10. Having pain in the area of the wound is a significant finding because it's often associated with infection. And osteomyelitis is a highly painful infection because essentially what's happening at this point is that you have bacteria that is really eating away living bone. The onset of new complaints of pain is something that really should have required physician notification because it's an indicator of a changing condition. However, there was no call made to the physician, and the resident continued to experience increased levels of pain. The resident also began to experience nausea, began to demonstrate changes in mental status, until one day the resident's son called the nursing home to speak to his mom. She wasn't making any sense. She was moaning and yelling. So the resident, or the son, hung up the phone and called the nurse's station to find out what was going on. The nurse went to assess his mother, thought that she might be a little dehydrated, and then called the son back to ask what he wanted to do. And he said, send her to the emergency room. The paramedics arrived shortly thereafter and brought the resident to the emergency room. When she arrived there, she was having agonal breathing, which is the kind of breathing that's really associated with the end of life. She didn't have a pulse or blood pressure at that point, and the staff at the emergency room attempted to revive her, but they declared her deceased within an hour of her arrival. Now, what happened after the resident passed is also of interest because it's something that you frequently don't see in this kind of setting. And that was that the coroner arrived at the hospital in response to the death being reported. And based on the condition of the resident, he recommended that an autopsy be done. And autopsies are done very, very rarely when somebody passes away in a healthcare setting. But the condition of this resident was such that the coroner wanted an autopsy done. And ultimately an autopsy was done, and the pathologist who did the autopsy certified the cause of death as being sepsis, meaning an out-of-control infection, the decubitus ulcer, and a finding that you almost never ever see on death certificates, a finding of neglect. And that was the basis for this resident's the citation against the resident, or against the nursing home for this resident's death. Now, there are so many levels of failure when it comes to the care of this resident. It starts when the resident came in the door and the staff failed to notify the attending doctor that this resident had a bedsore and needed orders. Instead, the facility kind of came up with its own ideas as to how this resident should be treated. There weren't ongoing assessments that were recorded as to the size and depth and overall characteristics of the wound. So it didn't receive any detailed attention or assessments until 19 days later, when the wound had declined to the point where it was at least a stage 3 wound. There was an inadequate care plan that was put into place, and that many of the steps that are customarily taken to address a risk of developing or having declining bed sores wasn't included, such as the turning and repositioning and offloading. The parts that were included, the use of a pressure relieving cushion on the wheelchair, that was included, but that wasn't done because when the resident arrived at the wound care clinic, the nurse practitioner noted that there was just a regular wheelchair cushion in place. Past that, there wasn't a revision in the care plan when the wound declined from a stage 2 to a stage 3, nor was there one when the resident returned with exposed bone after the debridement. That was a stage 4 wound at that point. And each of these declines in the wound from a 2 to a 3, a 3 to a 4, all required revision of the care plan. There wasn't notification of the doctor about the decline of the wound in any of those stages, nor was there notification of to the doctor when the resident began to make complaints of pain to the coccyx of significant level in the days leading up to her passing. I would suspect that if we get deep into the chart, we would also find that either vital signs weren't being taken, or that the measurements that are being recorded there make no sense in the overall context of the care of this resident. So what you have here is a sort of a stem to stern set of failures regarding the care of this resident, almost from the time that she went in till the time that she went out the door. And this is over a very, very compressed time frame. This resident was in this facility for basically a month before she died. And this wasn't a resident who was knocking on death's door. This was a resident who was living independently and was expected to be a short-term rehab patient and be discharged to go live with family as soon as she recovered from the broken hip and gotten some therapy to rehab her. So when you look at this situation, obviously there are direct failures in the care, but there are also some real clear failures in the management of this facility, in the sense that many of the policies that you would expect to be in place regarding the management of bed sores simply weren't there, and that's all sort of set forth in the citation. The wound care nurse told the state surveyor that when he began there wasn't a wound care nurse in place. He had had some experience in working in a burn clinic before, which is a form of wound care. It's not precisely the same thing. And he got fairly minimal training, next to no supervision, and there were no policies and procedures to help guide him in the care that he was providing. So you have poorly trained staff, you have missing policies and procedures, and you have a long series of failures in the care of this resident, all leading to a very painful, very preventable death for this nursing home resident. It's the kind of thing that just shouldn't have happened. My name is Barry Doyle. I hope that this has been interesting and informative. If you have any questions regarding this video or any of the issues that are raised here, or if you believe that we can be of help to your family, please feel free to call us. The number is 312-263-1080. The call is free. There's no obligation to hire our firm if you do call, or you can visit us on the internet at www.accidentlawillinois.com. We're happy to help. Thanks so much for watching.